Forgive me, Rick. I'm going to make this a fairly short introduction because I know you're going to give a wonderful paper. Lots of discussion afterwards, so I want to leave time for that. Rick Repetti is a tenured professor at CUNY. He's an APA board member. He is a certified philosophical practitioner and consultant. He's had 2 years of training at the Gestalt Center. He's both a yoga and meditation instructor. He is the author of numerous books and articles. My favorite is his book, Buddhism, Meditation, and Free Will, which I absolutely loved. I guess what I want to say here is that the first time, just ending on a personal note, is that the first time I met Rick was in our certification program. And before he had left the program, on his way home, I think he had a flourishing philosophical practice going. It's incredible. Also, the next time I thought of Rick was when I read his book, which I just alluded to, The Buddhism, Meditation, and Free Will. And the third time was when he showed up at one of our certification programs and gave a wonderful training module on how to develop a philosophical practice without an office. So I think Lou and I looked at each other, and particularly me as the so-called do nothing director. Oftentimes I have excuses. I'm old, whatever. We thought, oh, we should certainly have Rick, the do everything board member. So with that, no more ado, we'll listen to Rick's paper, which is called An Argument for Philosophical Practice.
Thank you, Fauna. That was very nice. Let me get this working here. Okay, yeah, it's actually an argument for philosophical therapy. And I wouldn't correct you if it wasn't for the importance of that word.
Okay.
So, yeah, the point of my paper is to argue basically that, and we've heard it, I think, in a number of the presentations today, what we do is frequently very therapeutic. We are trained by APA to call it educational and to sort of avoid the word therapy, but I'm arguing that we're pretty much doing philosophical therapy, or many of us are. And so I'm going to come up with some arguments in support of us actually being more explicit about that. What the practical dimensions of that are, legal dimensions, I'm not certain. This is a philosophical argument for now. So yeah, so we all have had 30 minutes with 15 minutes of Q&A. There's a much longer and more well-organized version of this, which will hopefully appear in the APA journal, but this is a kind of loose presentation just to kind of share my ideas with you and get some feedback. So at the end. All right, so I have nothing against psychotherapy. I trained for 2 years with Gestalt psychotherapy. I learned an awful lot, and I think there's a lot of really great things going on in the space of psychotherapy, and I'm going to critique it just to show that I think that the justifications for thinking that that's the model for therapy and that philosophical therapy is some kind of somehow or another unjustified or invalid or less than or whatever is some kind of mistake. So I'll argue, this is an overview of my argument, that there's very little that empirically grounds psychotherapy. There are little to no differences in outcomes from the different psychotherapeutic methods. This is an empirical fact. The few modalities that are at all effective are inherently philosophical, if not explicitly philosophical. Psychotherapeutic ethics, as practiced, is often significantly an oxymoron. I'll give you my reasons for that. Of course, a lot of what goes on is not unethical, but a lot of it is. I'll outline the two types of issues people take to psychotherapists. One is diagnosable mental illness. Those are things that fall under the medical model, and related issues related to those. And then the non-diagnosable issues of the otherwise mentally healthy. A title of Lou's book is Therapy for the Sane, right? And many of the issues that people bring to psychologists are the ones we heard about today when anybody mentioned any case studies. None of them seem to involve mental illness. I'll discuss the issues people take to philosophical counselors, right, to compare them. And I'll argue that the non-diagnosable issues that are often taken to psychotherapists can be and should be taken to philosophical counselors. Lastly, I'll talk about, well, not lastly, almost lastly, the one promising mechanism of change, as psychotherapists who study this call it, what actually accounts for good outcomes is inherently philosophical. And then I'll raise some considerations, concerns, and suggestions for the validity and establishment of philosophical therapy. Okay, so let me begin with some of my critique of psychotherapy. That when it comes to the medical issues, mental illness, right? If something really is a mental illness, it's typically a medical or chemical or neurological illness, and it's probably better suited to psychiatry, might require medication. Second, psychotherapy is not very strongly empirically grounded. Like I said, all the talking therapies are relatively equal. It's not clear what actually works. I mentioned about the oxymoron of psychotherapeutic ethics just by reference to the Diagnostic Statistical Manual, DSM, and its diagnoses. A few decades ago, homosexuality was a mental illness. Now it's fine, and toxic masculinity is the kind of medical pathology, which only refers to like some traditional heteronormative behaviors, right? So, and there's that. Then there's the over medication of things like attention deficit hyperactivity disorder, or the distribution of drugs like Prozac to people who are, a little unhappy or whatever. Everybody knows a whole bunch of people who are now taking these kind of serotonin reuptake inhibitors or drugs for ADHD. I keep meeting people my age even who say, "Oh, I recently got diagnosed with ADHD, and now I understand why I, failed in many other things in my life." I'm not so sure about a lot. This is very questionable and involves, billions of dollars of therapy sessions and medications. So I have doubts about all that. Then there's this thing, the so-called dodo verdict, which psychotherapists themselves know about, which is called that from the dodo bird in Lewis Carroll's Alice in Wonderland, who, quote, said, "Everyone has won and all must have prizes." That's just a reference to the quote. But the name of this problem, the problem is that empirical studies have shown that there are almost no differences in outcomes, no matter what, whether it's Freudian psychoanalytic therapy, Rogerian, Piaget, no matter what the method or a theoretical approach is, almost all the methods are equal in terms of outcomes. So there's almost nothing distinctive about the training that goes into this. And even more so problematic is that studies show that the greater training that a psychotherapist has absolutely it makes no difference on better outcomes for their clients. And the more years experience that they have, similarly, doesn't make a difference. And greater training and greater experience together don't produce any greater results. So the question, I was recently at a psychotherapy talk where a bunch of theorists in this field were lamenting this fact and trying to figure out what is it that justifies what they do. So one of the things that they sort of lean on in terms of justifying the fact that they have any authority to do what they do is called the common features model, or the core features model, where it seems to be the case that they all seem to agree, no matter what mode of counseling or modality, Freudian, et cetera, that what's in common across all the modalities is the most important thing is developing trust in the therapist relationship. And that, what is that usually based on? The authoritative credentials. This person has a degree from an institution where society recognizes that their authority on, human psychology. That's the first and most important thing. And even with those credentials, you still have to have a connection. You have to feel comfortable with your therapist, right? That's crucial. Second is that a mutual understanding of the issues arises in the relationship, like what we just heard about with that last case with Veronica, right? There was an understanding there. And then some kind of intervention, right? Where the therapist suggests, well, this is what might be helpful, right? And in the case of the last with Veronica, it was the Nelsonian Socratic dialogue, right? But it might very well be, since, there seems to be no difference in the methods, in the interventions or anything, that this is just a placebo effect. Here's an authority figure. They seem to get my problem. They said I should try this. I try it. I feel better about myself. It could just be placebo. And I don't have a negative view of placebo. 20% of people on any kind of drug test have a great result without the real drug. So placebo is good. All right. However, those more recent psychotherapies, like cognitive behavioral therapy, are somewhat more empirically effective, right? There are some that are a little better than the others, like cognitive behavioral therapy. Those are all derived from philosophy. So there's CBT itself, then there's rational emotive therapy. These are all kind of variations on Stoicism. Logotherapy is different. It's a Viktor Frankl existential therapy, but these are all very philosophical. They're mindfulness and all the varieties of mindfulness. MBSR is mindfulness-based stress reduction, mindfulness-based cognitive behavioral therapy, et cetera. There's a dozen others, right? And of course, mindfulness, by the way, is derived from Buddhism and Stoicism. And then Gestalt therapy, which pretty much the founder of Gestalt psychotherapy was Fritz Perls, who was highly and heavily influenced by Asian philosophy, particularly Zen, right, which is related to mindfulness. Okay, so philosophical therapy, I think, is just as valid for anything other than mental illness, if not better. And here's a way of kind of partitioning these. Those kinds of problems that are, let's say, what Lou calls therapies for the sane, psychologists normally deal with them, or we'll put them in the upper left-hand corner of mental health. But the more explicitly philosophical problems go in the lower triangular, semicircular kind of triangle circle thing at the bottom, what we could call philosophical health. People have explicitly philosophical issues, but they're bringing them to their psychologist because they don't know about philosophical counseling. And then mental illness, partition that off. Psychologists, they will treat mental illness, but if they think that it's a certain kind of diagnosis, then they'll send that person to the psychiatrist to get drugs or whatever, right? But what I'm saying is the 2/3 on the left, mental health and philosophical health, philosophers or philosophical counselors can deal with those. And these are general categories on the left. On the right are just some examples, right? So ordinary issues of everyday life, like divorce, change of career, ordinary anxiety, whatever. Those are in the mental health category. In the philosophical health category, somebody struggling with conflicts, dilemmas, questions of meaning, all sorts of things like that. But then in the mental illness category are these things that are, disorder, the D at the end of the first two things, this disorder, that disorder, and so on, right? So what I'm suggesting is that philosophical therapy is fine for everything except mental illness, if not better than what you get from psychotherapists, for reasons that I'll go into in a moment. So those diagnosable issues, I think it's important for philosophical counselors, and the training at APPA makes it clear that we need to not treat these things and refer them out the minute we sense that that's the problem. Those are probably better treated by psychiatrists, in my view, rather than even psychologists. And the psychologists who I was listening to at this conference recently, they pretty much agree with that idea. Right? Psychosis is some kind of break from reality, major depressive disorder, generalized anxiety disorder. And I'm going to say there might be versions of these things that aren't really disorders, but suppose that they actually are, then they fall into this category, right? These categories: bipolar disorder, schizophrenia, post-traumatic stress disorder, and that's also on a spectrum. Obsessive compulsive disorder, social anxiety disorder, panic disorder, ADHD, attention deficit hyperactivity disorder, anorexia, bulimia, borderline personality, autism spectrum, substance abuse, and various phobias, dementia and Alzheimer's disease. Let me just pause here for a moment and repeat again. There are a number of things in this category that many philosophical counselors think don't even belong in this category. But that's an open question. We could talk about that later. I'm not an expert, but I'll say something about why I think we philosophers who are doing this kind of work need to be clear about what these things are so we can recognize them and not get involved in them if they are disorders of this kind of this order. Okay. All right. So then there are gray area cases. I mentioned spectrums where we can remove the word disorder, and there are not mental illness versions of these issues. So on the left side, I have some of these mental illness version, and then on the right side, remove they're not on the heavy side of the spectrum, they're on the lighter side of the spectrum, depending on the case, that are issues of philosophical health rather than mental illness. So take major depressive disorder. Many ordinary, healthy, sane people have event-based depression. They get into a car accident, they're lying in bed, they don't have the will to get out, whatever, or they had an accident, they're in a wheelchair, they don't know how to respond to it, or they got a terminal illness, diagnosis, and they're depressed, right? These are event-based depressions, not chronic, lifelong, deep mental illness problems. Generalized anxiety disorder, I don't even know if that's really a disorder unless it makes somebody dysfunctional, right? But there's all sorts of anxiety that are existential in origin or event-based, right? This somebody threatening me, I have a lot of anxiety about it, or my son is in the Israeli Defense Forces in Gaza right now, I can't sleep at night, right? So these are event-based or existential forms of, philosophers who want to do therapy need to be able to identify the differences between these things. PTSD, my therapist in Gestalt told me I had multiple PTSDs from various things, traumas that happened to me in my life, but they never made me dysfunctional, right? So to me, that was circumstantial, stresses, adversity, right? It depends. It's a matter of judgment. Social anxiety disorder, right? If you have afraid to go out, you have agoraphobia or something, it might be related to social anxiety disorder, but you might just have some social anxiety, which is a function of being isolated, socially isolated. I've had a number of clients who I could tell from speaking with them that they lacked a support network, and I tried to help them figure out ways of getting outside of their isolation. And that seemed to be all that they needed. Panic disorder, of course, sometimes people have fear and insecurity. I gave some examples earlier, like the bully's outside waiting for me at 3:00. What am I going to do? Should I face him or call the security guards to escort me to my car, right? Attention deficit disorder, I have doubts about whether or not, I would imagine that if somebody really can't focus at all and they can't function, that's one thing. But I think one of the presentations that we heard about was about this techno hijacking of our attention, right? So almost all of us are facing attentional challenges. Whether or not this is a mental illness, I'm not so sure. It depends. Like once again, there's a spectrum here. And the bulimia and anorexia, those are serious eating disorders. But then there are people who have milder versions of this that perhaps we could help them with. And then substance abuse, of course, that people develop negative habits or dependencies. It doesn't necessarily mean that they're in a case of mental illness where they need some kind of psychiatric help, right? So this is a whole range of things that I think philosophical counselors need to pay attention to and that we can address fruitfully. And then there's those other things that are the non-diagnosable issues that people already bring to their psychotherapists. So I'm just going to list some of those here. Relationship problem. I mean, think about I don't know what the percentage is. It would be great to do some research on it. What all the issues are that people bring to psychotherapists and that those are treated like mental health problems, relationship problems, life transitions, divorce, relocation, job change, grief, loss, death of a loved one, career counseling, job stress. Oh, my boss is driving me crazy. I don't know how to cope. Self-esteem, low confidence. I'm not assertive enough. I need to ask for a raise, or whatever it is. Right? Personal growth and self-improvement. Just got a diagnosis of terminal illness, or I've got this chronic illness. I'm having difficulty understanding how to cope with it wisely. Parenting challenges. Oh, I have a client who came to me and said, I don't know how to deal with the fact that my teenage daughter is thinking about transitioning, trans male thing, right? Stress management, communication skills, existential crisis, right? Loss of meaning, existential crisis, spiritual or religious concerns, anger management, loss of meaning or loss of faith, life purpose and fulfillment, identity issues and life goals. I think all of those are things that philosophical counselors can deal with quite intelligently and perhaps maybe even better than psychotherapists. Now I want to list some clearly philosophical issues, some that are explicitly philosophical and some implicitly. Meaning of life. And when people come to me with that question, I try to redirect them to think about meaning in life instead of meaning of life. It's a kind of existential approach. Existence of God, or missing the sense of the sacred, or experience of transcendence. When I was younger, I had religious beliefs. I don't have them anymore, but I felt something. I want to recapture that without these beliefs that I can no longer ascribe to. All right, these are clearly philosophical issues. Selfhood, agency, autonomy. I can thank Sam Harris and other critics of free will, like Robert Sapolsky and others recently, who said there's no free will, there's no self. And then I wind up getting clients because they're like, I don't understand. What does it mean if I don't have a self, right? This is clearly a philosophical issue. I don't think it's a psychotherapeutic one. And then, of course, people who have dilemmas, whether they're normative or moral dilemmas, these are clearly philosophical issues. Questions about the obligations to self and others, right? They might wind up like naming that in a way that doesn't sound philosophical, but it is. Any kind of torn decision is one like a trolley problem where we have to figure out what's a wise way to resolve it. Virtue and wisdom cultivation. I want to become wiser. I want to be a better person. How do I do that? I've got problems with my belief system or cognitive dissonance. I was raised to believe this, but this, or my political party is always, I thought it was this way. And now look at what they're doing. I don't know what to think anymore. Or skepticism, cynicism, nihilism, right? Those are clearly philosophical. Now, implicitly, so implicit philosophical issues. Conspiracy theories. I had somebody come to me who seemed to be stuck with conspiracy theories. So what did we do? Virtue epistemology. That was very helpful for that person. Life path decisions, college, career, relationships, right? Those are implicit. Like, what are your underlying values? Or as Ayn Rand would say, what's your premise? Right? These are clearly philosophical questions. Personal purpose, fulfillment, obviously, personal growth, self-improvement. What is the value that you aspire toward, and why is that good for you? Loss of faith, identity issues, and life goals. Of course, some of these appeared on the other page, but I'm putting them here because I think they're implicitly philosophical. Grief, loss, death. How do we cope? Existential questions. Spiritual, religious concerns. Existential, straightforwardly existential crises. Cancel culture, polarization, censorship, and then also what we heard about earlier, the hijacking of my attention. How do I deal with that? All right, these are implicitly philosophical issues. What should I pay attention to? How do I thrive and flourish as a human being? Okay. So I said that there's one recently very promising empirical finding. It's called memory reconsolidation. It's the one, what is it called? Let me pause that for a second. Mechanism of change, like what actually works when therapy works. Well, this is one of the things that studies seem to be showing very promising results with memory reconsolidation. So how does it work? In the secure, supportive therapeutic relationship where there's that trust, or as I've experienced, I've led guided meditations where this has happened, where I run the meditation in a way that brings about the same effect. Revisiting an early memory that initiated a negative self-image. We heard about that before also with Veronica, right? She saw about that negative image and how it was formed and started to think about it differently, right? So what we do when we do this kind of work with memory consolidation is we try to get the client, guest, patient, whatever, whoever, to sort out the different kinds of memory around this kind of event. Episodic memory is like when you can visualize, oh, I was standing in the kitchen. I can see the picture on the wall, that's episodic. Semantic memory is, I remember I must have been around 12 because I was in the 7th grade. That was the teacher of these are facts. Like I remember that I learned that Christopher Columbus landed in the Americas in 1492. Semantic memory, factual memory. There's an emotional memory, what it felt like, a psychological memory, what was my mental state at the time. And then there's narrative elements. Those are the beliefs that you form about yourself. I'm no good, I'm dangerous, I'm this, I'm that, right? What do? We look at it from multiple perspectives and try to find a way of reframing the understanding that the younger, less mature, less wise person responded with forming these false beliefs about the self and internalize them. We get them to reframe them from the perspective of this trusting, supporting, nurturing, the therapeutic container, right? And it works. Right? The shift can happen in any therapeutic modality. Remember the dodo bird effect. It doesn't matter no matter what form of therapy your therapist practices. If they do this seems to be what works the most. And let me tell you the case of someone I'm going to call Hannah in that guided meditation. I did a 20-minute meditation for a group of maybe 25 people in one of the weekly meditations that I was running. And I had the people kind of just get them into a good state of mind where they were viewing themselves positively with compassion and care. And, I make some suggestions about how their consciousness is ultimately pure, the same as in Buddha or anybody else, blah, 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 whatever, all these things to get them into a kind of the equivalent in a meditation of being in that supportive therapeutic space. and then invited them to think of an early memory that has some kind of emotionally unresolved or undigested experience, right? And just conjure it up. And then I walk them through thinking about the semantic memory versus the episodic memory. What are the images? What are the feelings? This, that, and just have them look at it now from a wise perspective in a meditative, contemplative, self-nurturing state of mind. And this woman, Hannah, we didn't have time for Q&A after this one, just a minute or two. She didn't speak. Next time I saw her, we had a meeting where we had an hour of Q&A. She took almost a whole hour talking about how transformative that experience was for her. It was really mind-blowing. She said she had this insight. How did she put it? When she was about 4, she accidentally hurt her sister really bad. It was an accident, but she felt terrible about it. She was also in a stage where, in that saying no with that autonomy thing, no to her parents, but her parents immediately insisted she apologize to her sister, and she said no. And they were very judgmental about her, and she formed these beliefs about herself that she's stubborn, she's dangerous, she can hurt people that she loves, and a bunch of other things like that, all these negative self-images. And she realizes, I was 4. I've been carrying that ever since then, and it's inhibited the way I relate to everybody. She just had one cascade of insights after another over the course of a few days when she spoke to me next. And then a week later, she told me it was still going on. It was completely transformed her life. This is just one anecdote, but even in a guided meditation. I wanted to mention that because I always think that it could be a useful technique in our kind of work to guide meditations with our clients. All right. Just like to do a Socratic dialogue, Nelsonian style, with an individual client, modifying it to suit the case. Right. So also, I've seen Pierre Grimes do this sort of work superbly, rest his soul, with his philosophical midwifing work on dream analysis, where he just says, okay, who has a dream? Somebody has a dream. They start talking about it. And he says, at that point in there, what was your mental state like? What does it feel like? Your state of mind. Can you remember the earliest time you felt that same state of mind? And he would kind of walk the person through a kind of midwifing questioning and go through the exact same kind of process. Spectacularly effective. And I see that Regina is here, and I'm sure that when she did the validation of his work, she probably sees elements of what I'm talking about here and what Pierre does. We'll find out later. And here's what I say. Philosophers in general, not just philosophical counselors, but philosophers in general are highly skilled in conceptual reframing. It's practically all we ever do. We have hundreds or thousands of hypothetical and counterfactual frameworks in our conceptual toolkits. And then, of course, philosophical counselors probably have even a few more. Okay, so that's one of my main arguments. So let me summarize. I have a few minutes left. Just summarize my position. Like I said, this is a sketch, and I hope that the paper that's longer and has more detail and justifications and references for my claims about empirical research and whatnot, that'll all be in the paper. But let me summarize my argument. So premise 1, psychiatry, and this is not a straightforward deductive argument, but more inference to a kind of good explanation, if not the best. Psychiatry is more suited to address mental illnesses than psychology is. Psychotherapy is only weakly empirically supported and lacks any real expertise. Right? The dodo effect kind of amplifies premise 2, that the modalities are mostly equally effective or ineffective. A couple of them are more effective than the others. But that's my next premise. Those that are a little more effective are philosophical in origin. Psychotherapy addresses, psychiatry in premise 1 deals with the mental illness. I think they're better suited to it. I'm not saying talking therapy can't help, but it generally doesn't shift much, talking therapy, for mental illnesses, right? So that's the psychiatry. So what's left for psychotherapists? Those non-diagnosable issues, right? They address that. And the most promising mechanism of change that they've found, or at least right now, it seems that there are a lot of research is going on about it, is this memory reconsolidation, which is a type of conceptual reframing. And philosophy is all about that. All right. So I think philosophy can better address those non-diagnosable issues. To quote Ibrahim, I think it was Ibrahim earlier who said, everything is philosophy, right? Oh, no, it wasn't him. It was Professor Wang who said everything is philosophical. So I'm taking a similar view. And I think that there's no good reason to not consider this kind of work therapeutic. Since it's most fresh in your memory, there's the case I just mentioned of Hannah, but also of Veronica, right, with Socratic dialogue. All right, a couple of caveats, provisos, and possibilities. So if we begin claiming the word therapy and therefore territory of therapists, right, we'll be targeted by those therapists who make tons of money in the psychotherapy space. So I think we will need, if you want to do this kind of work and call yourself publicly a philosophical therapist, it's probably wise if not just you, but us, this community, if we can work with philosophical counseling friendly psychologists and or psychiatrists to design a course just for this purpose, specifically devoted to mental illness diagnoses, precisely in order to more confidently assert that we can recognize them, mental illnesses, in order to not address them, but rather to refer them out. This is a kind of defensive move against the likelihood of what happened in the very beginning, as Lou Marinoff would say, when psychiatrists accused us of practicing medicine without a license. I forget Lou's follow-up funny retort to that. Maybe he'll tell us that during the Q&A. But here's a promising thing. I have a friend who works in the insurance industry, and I had a conversation with him about this, and he thinks that we can approach the insurance industry to recognize the tremendous savings, and it's all about money for them and risk management, right? And like prediction markets, that's what insurance is, right? The tremendous savings that they could realize by replacing Prozac and the like and ADHD, not only the 10 years of therapy, but the millions and millions of dollars on the drugs, right, that go with these kind of things that don't really belong in the mental illness category, with philosophical therapy. And perhaps first, like a stepping stone toward this being recognized completely by the insurance industry, is through employee assistance programs. And those are programs that try to actually save money by, creating this kind of pool of sort of support systems for employees that are less expensive for them than the regular use of their insurance options that they also afford to their employees, right? And eventually maybe the insurance industry will completely adopt it. So like I said, with only a half hour to present, I already went 1 minute over. I want to have Q&A. For more on this, look forward to my paper. That's all I have to say. Thank you. Okay, so Lou, you have a hand up?
Yes, I do, Rick. I want to thank you very much. I'm going to put spotlight on you again. Just bear with me for a second while I manipulate the controls. Patricia also has a hand up, but we'll let Vonna handle the Q&A. Okay.
Great.
I just want to spotlight you and thank you very much for the presentation, which has been really great. I'm not able, Rick, I've lost control of this. I am a host. You seem to be able to spotlight people.
All right, let me try. Let me
spotlight yourself and spotlight yours truly. And
spotlight you.
Yes, and Vonna, who will moderate the Q&A, and then we'll have a town hall at 4:45. Okay, and if you could spotlight yourself, please.
I'm working on it.
You're working on it too.
Spotlight.
There you go.
Vonna, let me get Vonna in
you
here.
somehow have control of this. I'm so relieved that you do. Thank you very much for all this.
1 second to spotlight Vonna. Okay, great.
Okay, so I just want to make a couple of comments. You've been very, very, very thorough as always, and I'm impressed that having been last today to speak, you still have the same energy as though you were first, and the same acuity. So I'm very impressed at the end of a long day that you can do this as it were, so effortlessly and effectively. I want to say that we have to be very careful on two issues. One of them is the lesser one, what is, you're calling insurance, third-party reimbursement for services. In general, the only way to obtain that in the USA at present is to be recognized by governments and have either a license or certificate or registration. I'm sure that we agree, after a lot of years of argument, we think it's a really bad idea for governments to regulate philosophy. Okay, that would be beyond catastrophic. We think it's a very good idea for governments to regulate medicine and other, and social work and law and other professions, architecture, you name it, engineering, any kind of profession which can cause great good and or great harm to people should definitely be regulated by governments, and we're all in favor of it. I'm not so sure any philosopher would want to report to some bureaucrat in order to be permitted to do philosophy. That would be a big problem for us. So we have eschewed that route for a very long time for that reason, and we continue to eschew it. Even if we wanted to go that route, the numbers will not support it. Do you know how many psychotherapists there are in Manhattan? Licensed, you want to take a guess how many licensed psychotherapists there are in Manhattan? Well, it's probably minimum, the more than taxi drivers, I'm assuming. There's got to be tens of thousands of them. Okay? How many philosophers have we certified worldwide in 25 years? About 600. All right. So if you're saying it's going to be cost effective to refer people to philosophers, yes, in principle it would be, but in practice we are far too thin on the ground for actual economic benefits to be reaped from that move. We would have to raise more than a regiment. We'd have to raise an enormous army, and at this pace, it will not be us, okay? So we might leave the thought to the subsequent generation. But the most important point, and I'll finish with that, I've absolutely agreed with you all along that philosophers who want to be counselors or in any kind of practice at all need to take more extensive training, obviously, than what graduate school provides. And that's why we've been successful with our certification programs, as you well know, because you're part of them. We give people the tools they need to build a practice. We're not teaching anybody philosophy. They have enough, but they need to know how to practice that as a profession, which certainly they don't get in the academy. Okay, but we are much more proactive when it comes to asserting what we do rather than denying what we don't do. We're skating on very thin ice if we start thinking that we can recognize Axis 1 and Axis 2 DSM problems in order to make referrals. Then we're practicing medicine without a license. We're falling exactly into the trap that these guys want us to fall into. We're not qualified. We're not even qualified to suspect it in our dreams. I want to share one slide, and I would urge you, Rick, please make this part of, whatever you do in the future, because this is what we do. This is what we can say that we do, and this is what's been approved by federal statute and replicated at any number of public universities in the United States, where we are saying we are qualified specifically to recognize these 5 categories of problems, whereas other co-professionals are either less well qualified or not at all qualified to recognize them. If we have a scope of practice, which we do, I mean, most of you who've taken our training were asked to buy the textbook and read this, so, but there's the page in question. This is what we do. And because this is approved by federal statute and replicated, it's a benchmark. And we don't have to skate on thin ice by saying, well, if someone's mentally ill, we refer them. We're not qualified to know that. We're qualified to know whether someone's rational or functional and whose problem lies in one of these 5 categories. And I really wanted to emphasize that because this is where we can stand against all these attacks. And what I said to the, finally, what I said to the, thank you for that anecdote, when the former president of the American Psychiatric Association accused me of practicing medicine without a license because I was resolving moral problems for my client. This was on the front page of the LA Times. They loved it, right? And the response they loved too. So they printed it. I said, well, if he thinks that helping people resolve moral dilemmas is practicing medicine without a license, then he needs philosophical counseling. He's practicing, if he's doing this, he's practicing non-medicine with a license, which is, so right back at them. But that's only because you guys are laughing. I'm glad. You should be. But it's only because we have a place to stand in our scope of practice. And I'll stop there, but your presentation was fantastic. I'm not going to say all the 99 great things about it, because you know what they are. But this is one thing where we need always to make sure we have that place to stand, okay, inside the scope, and then we're safe. Thank you so much, Rick.
Yep.
Really well done. Bona, please go ahead and share
Thank
questions.
you very much for a wonderful
Thank you, Lou.
presentation. And I think a lot of us are agreed with you on the theoretical issues, but we have some the practical ramifications of what we should do, or perhaps another issue. But I see two hands up. Patricia, I think yours was first.
Okay, can you hear me? Yes.
Yes.
Okay, thank you, Rick. Partly of my question has been anticipated by Lou, so I don't want to repeat because I was some observation that Lou anticipated in a way. But really, I do appreciate, and I agree totally 100% now, but not 10 years ago or 12 years ago, about the use of the word, the legitimation of the word therapy. Because I think that using the word, which once I felt like totally out of our field of competence, my word was education. That's it. We educate in a very Socratic way. We take out the best of the person, following and helping the person to find him or herself, issues and moral issues and whatever, and meaning of life, meaning in life. And I agree, and we are still there. But using the word therapy in a sort of marketing can help our work, our profession. Because really, still now, some people don't understand what really we do. And if we use the word therapy, the therapy of the soul, the therapy of the mind, not the illness, not the body, we are not doctors, we are not psychiatrists, but the therapy of the mind. I think that philosophical insight is the oldest form of therapy, of the soul and of the mind, as Pierre Grims very often said. So I think that therapy is not, I don't feel ashamed any longer. I think that the legitimation of the word is very, very important. For the rest, I agree with Lou anyway. When the government tries to put bureaucrats and rules and norms, it becomes very dangerous. Unfortunately, in Italy now, because of the profession has been inscribed into associations recognized by the Minister of Economic, and apart from public instruction or research, now in a way, there are a lot of obligation and bureaucratic things that really, instead of opening, in a way are closing. So it's a kind of contradiction, or it's a counter effect. It's just like a pharma product which produce a side effect and not unexpected. So I think that the observation of Lou regarding, thanks God, the government stays out, we are not engineer, and it leaves us more free to move and to research and to say freely what we think. So anyway, I really appreciate a lot your presentation, and really the word therapy that it's a sort of leitmotif for you. This research of definition of what really philosophical counseling is. And in my personal experience, I collaborate with a psychiatrist since the beginning, and no psychotherapists, because they see us like not enemies, but like competitors. So, but psychiatrists don't. So we can integrate very well. And last observation, thanks a lot for using slides, because I think that especially late at night in Italy, when you listen to a person and see slides, it's much easier. Reading just papers makes so difficult to follow 45 minutes of reading. It's impossible. It's not a frontal lecture. So I think that thanks a lot for your slides. So clear, so rational, so well done.
In response
to
comments, Rick, would you,
Grazie to you.
It might help in responding to these comments if you would clarify what you mean by therapy also.
Me? Is this a question? What do I mean by therapy?
Yes. I mean, you're saying that philosophical practice and counseling can be therapeutic. Is a therapy. What do you mean by therapy?
Well, let me answer this in the cheapest way first. When the psychotherapists help people with all those problems that I said belong in their category and in ours, they're calling it therapy because they're improving people's lives. People are stuck, they're knotted, they're suffering, and they come out of it not being stuck, not being knotted, and feeling healthy and more functional. That's what I mean by therapy. And I think, one of the things about me, anybody who knows me for a while knows that I kind of have to call a spade a spade. So I feel like a moral obligation to be honest about the fact that we're doing therapeutic work. We have to, okay, leave the government out of it. We're doing therapeutic work. I mean, there's aerobic therapy and the aquatic therapy, and some of those things need to be regulated. But yes, I like Lou's objection that so I have to I have to try to thread the needle in between getting insurance agencies to want to support us and leave the government out of it. That's the challenge. I'm an optimist, Lou. I'm going to work on this. I'm a little younger than you. I might have an extra decade to work on it, but I'm not giving up on my hope about that.
Don't ever give up, but we got to get Jude. Jude, I just have to say something, Vaughn, about this. Pardon me. I'm very excited now by what's just transpiring. And Rick, the etymology, if I have the Greek right, a therapist is just an attendant, somebody who attends to something. So, your flute teacher is actually a psychotherapist in the original etymology, because your flute teacher is attending to your breath, which is also psyche, right? So, the person who parks your car is the valet parking service. That's vehicular therapy. And there's a magazine you get on the inboard. I've seen this on airplanes. I took a picture of it somewhere. I'll share it with you. It's a magazine for shopping on airplanes. It's called Retail Therapy. So excuse me, if they could call shopping therapy, then that word is now like Kleenex or any other thing that was once owned by somebody, but now it's in the public domain. Okay.
Well,
So
Lou, you just gave me a great idea. I'm going to start a campaign. When I teach people yoga breathing, this is now psychotherapy. I'm going to reclaim the word psychotherapy in New York State.
then you'll get in trouble.
I know.
Okay, Jude has been very patient about having his hand up, so let's give him the floor.
Thanks. Can you hear me okay?
Yes.
Great. So at first, I just wanted to thank you, Rick. I really liked that presentation. I found that very, very helpful, and I'm really looking forward to the final paper. I just wanted to offer a couple thoughts, one theoretical and one more pragmatic. So the theoretical point was just about drawing the distinction in terms of diagnosable versus non-diagnosable. My understanding is that there's quite a bit of critique among research psychologists that and some psychiatrists as well, that a lot of the diagnostic criteria over time with the evolution of the DSM have become kind of in this, the bar has kind of been lowered quite significantly. And so there's a lot that can be diagnosed or that is diagnosable that probably most people intuitively would not think constitutes a mental illness. So even the diagnostic criteria for depression can be very, very low. So anyways, that's the theoretical point, but I realize, partly to Lou's point as well, that to start addressing issues that might not need a psychiatrist, that a philosopher might be more than enough, it does start to step on the toes of psychiatrists, and that's where you get that kind of pushback. So anyways, that's why I wanted to raise it as a theoretical point. Maybe it's not practical though. The kind of pragmatic point I wanted to raise was just from reading kind of the services offered by a lot of different psychologists. I've noticed some who will offer therapy, like standard, whatever, mainstream therapy, and then they will also offer coaching. And I noticed, and I think there's an organization of cognitive behavioral therapists in the United States that also draws this distinction between therapy and coaching. And they kind of just draw the distinction at, therapy is for treating mental illness. Coaching is for treating people who are not mentally ill, but who have issues, problems, challenges, goals that they want to work on. And so I'm thinking maybe it makes some sense to think about philosophical counseling as a form of coaching. Another way I thought to put it, and I don't really know the distinction here, but I'm familiar with a psychologist, Martin Seligman. I think he's at University of Pennsylvania, and I think it was him that innovated this idea of positive psychology. And similarly, the distinction being that, psychotherapy or abnormal psychology is about restoring people from a point of mental illness to health, and then positive psychology being about, treating healthy people to try to improve them in some sense. So I was thinking also coaching or positive psychology, I wonder if might be more, not theoretically, not necessarily, but practically, it might be a better way of framing like a place for philosophical counseling. I just as an aside, I know in my jurisdiction, if you don't have a license to practice psychotherapy, you can't say that you offer therapy. So I'm just stuck. Anyway, so that's all I wanted to share about that.
You can't even use the word therapy. What's your jurisdiction?
Ontario in Canada.
Oh, okay. Right.
Yeah.
Wow. Well, this thing about coaching, yeah, it's brilliant. I guess everybody who's doing this kind of work has to decide how they want to build themselves and describe what they do. And this is another, an interesting possibility about, kind of validating coaching as some kind of insurable or thing like employee assistant program things or whatever. Maybe that's a way to go. But when you mention this thing about when I read these ads in Psychology Today and because I have a listing of myself there, and sometimes I'll go in and just look at what other people are saying. So many of them are saying things that are in the categories that I've been describing. Mindfulness, this, that. None of it sounds like even traditional psychology to me. It sounds like more like what we do. And I'm just like, I don't know, this is just, it's fraudulent. It's not fair. And when you mention the coaching, it makes me think of, all right, all those people who come to them for coaching, if that psychologist wants to get that person's health insurance to pay for the session, they're going to find something in the DSM, which is a kind of Procrustean category that they're going to fit that thing into to get money. It's economically motivated fraud. All right. So that reminds me, I had a dentist that was corrupt when I was a teenager that would say, you need this done, but the insurance company won't cover it. But if I put it down as that, they'll cover it. And I was like, no, I don't want that on my name. Right. This is the same thing that's going on. Oh, you have anxiety because you're not sure how to deal with your divorce? No, it's not anxiety. It's the divorce that you're going for counseling for. This is unethical. It's fraudulent. And most philosophers just wouldn't do it. But psychologists have no problem doing it. I'm not trying to indict all psychologists, but all those everyday problems that go into the psychologist's office that are paid for, it's probably 80% of the clients who come in have insurance. That's why do you take my insurance? No, I'll find somebody else. Right? So those things are going down as anxiety, as this, as that. It's all lies. It's just
Rick,
that's when I said it's oxymoronic. Psychotherapeutic ethics is significantly oxymoronic. As practice.
I see some other hands up. Kermit? Kermit?
Yeah. Well, first it occurred to me to say more than once when I've had a client that said that they had depression, I said, you don't have depression, you have Down syndrome. And then after we laugh, and then we'd laugh about that, but then that would lead into a discussion about what exactly it was that they were dealing with. And then we would create a conceptual framework that was not depression. And then they had a place to put that. And that was useful. I also want to mention the other side of the problem that you just mentioned about, having to lie, which most honest people that I know in this field do that. They know that they're lying. But the other side of that is when I've tried to do the other with people, they're like, well, they either can't afford to hire somebody, or they want to be within the system. They want the insurance that they've been paying for or that they have. to pay. So I've actually said to people who had, say, Medicare, where they had, say, a $10 copay, and I've said, give me the $10. I'll work for you for that. And they end up not doing that. They don't want to, I mean, it's very difficult for people to step outside of the economic system that exists and feel that they're legitimate or that they're getting what they deserve or what they need. So it's not, I mean, I totally respect, of course, that it's, that we end up, I mean, I don't do it anymore. I just can't. I can't write down a lie anymore, ever. I won't do it. But that means I can't work with a lot of the people that I otherwise would.
Right. Yeah.
Rick, do you want to respond or?
No, I have nothing to disagree with there. I think that's really honorable, and you're probably in the minority among people who have to write out those little numbers in the boxes for the insurance form. But that's very
I have to
commendable.
acknowledge I don't need to do it for a living. So I have to give respect to all the people who don't have that choice.
Yeah.
I see that,
Yeah.
who was it? Michelle, wasn't it?
Yeah, Michelle had her hand up, but then it went down, and now.
Well, I noticed that there were some comments in the chat, but I can't multitask. And in honor of cognitive autonomy and not having my attention hijacked, I'm not going to go there. Anybody who had a question in the chat can raise it now, but we're already 10 minutes over our time.
No, well, we're into the town hall, Rick, so it's okay.
Okay.
Michelle would like to speak, I think.
Yeah, I'll just say it really quickly. It was just to speak to Jude's point. I'm a counseling therapist in Canada, and it's, as you know, kind of tricky across the provinces with the state of regulation. But my understanding, I'm not a lawyer, is that therapy is not a protected title or activity. So you can't call yourself a psychotherapist in Ontario or a counseling therapist in Alberta or a clinical counselor, whatever the words are going to be. But you can use therapist. And there's a woman who's I think she was a counselor and a coach and a lawyer, did a couple of podcasts about how you can work as a coach and as a counselor and sort of do that ethically and what some of the distinctions would be. But one of them is you can use therapists. So if you have a life coaching course site or a philosophical counseling site, you can refer to your other work as your, not clinical, therapeutic work or your work as a therapist, because it's ultimately meaningless. I mean, most people think about it in terms of psychotherapy, but as everyone's pointed out, it gets tossed around and attached to any number of ideas and activities. So you're safe there is all I wanted to say. You
Absolutely.
It's only psychotherapy. You can't say you're a psychotherapist.
Correct.
What I thought. Yeah. That's what I thought.
And in New York State, as in many other states and provinces, Michelle, we have all kinds of groups vying for licensure. We have art therapists, music therapists, dance therapists. They're free to use that term, and they should be, absolutely. But as was earlier said, we have positioned ourselves more originally as educators. So education is also therapy. Maybe, Rick, we need to make that connection, that education is therapeutic too, on a given day. But over to you. Jude,
I just wanted to say thank you very much, Rick. That was very enlightening. I really appreciated your presentation. Thank you.
Thank you for that and for the clarification, because I thought it was the word psychotherapy that's regulated, not the word therapy.
Right.
One quick question, Rick. I think if you start using the term therapy, you're going to have a war. You're going to have a war from the psychotherapists on the one hand. And what's worse, we're going to have a war with the European philosophical counselors who have spent eons of time trying to distinguish philosophical counseling from therapy and accusing American counselors of simply doing therapy, whereas they do the real philosophical therapy.
Yeah, I know. There's landmines in every direction. I've got to thread that needle. It's the Hyla and Charybdis thing going on there.
We're going to blame you, Rick. Okay, Lou, do you want to?
Yeah, our potential for collaboration with psychiatry is getting stronger and stronger. And that's a common bond between us and Europe. because the latest generation of psychiatry students are not being taught to talk to patients whatsoever. They're called molecular psychiatrists. They're only being taught pharmacology. So basically, they're only prescribing drugs to stabilize this or that issue that they suspect is going on in the brain. And it's very clear from, being human that people need to talk and will always need to talk, regardless of what medications they're taking or not taking. So I think a fruitful way for us to go would be to build more bridges between philosophy and psychiatry, so we can take up that slack of talking, because that's what we can do. And they can keep, prescribing whatever they think they want to prescribe. So maybe that's a good way for us to achieve more of our growth, actually, without being their servants, or their handmaidens. We can be their partners in some way.
I see a hand raised,
Yes,
Michelle.
Michelle again.
Yeah, Michelle. Again.
Thank you. Just to change tacks, I was wondering, I appreciated your talk on the dodo bird verdict and the common factors model, and 70% is relationship and extra therapeutic impact on increasing wellness. I was wondering around your research into the efficacy, I noted that analytic sort of psychodynamic therapy wasn't listed as sort of philosophical. So I was interested in that, I guess, especially I've been following a few sort of British psychoanalytic practitioners, namely Dr. David Bell, really, in the UK. And it seems quite philosophical in its roots and background, way out of my league, by the way. Like, I'm not a psychoanalytic practitioner. But also Jonathan Shedler did a paper in 2010 about the efficacy of psychodynamic psychotherapy that I think you might find interesting. Allegedly, it shook things up quite a bit because he really took issue with the alleged gold standard of CBT and the alleged evidence base for it. And he takes great issue with the current state of my profession. But anyway, I think you might be very interested in reading his papers in general, but that paper in particular.
Could you put the name of the author and the paper in the chat? I just put a link to a really good summary of the work on memory reconsolidation, which is the most promising recent thing. But as far as your remark about that form, I didn't mean to be representing all the forms of things that, that list is growing by the day. It's just one new method after another that's sort of drawn from philosophical understanding or actual traditions in philosophy.
Okay.
But I'd be happy to read that. So please.
I will. Okay. Thank you.
Thank you.
Lou, do you want to?
Well, I think that we're getting close to actually closing the meeting. If anybody wants to question or comment, we could certainly run a little bit over. But we've kept to the clock all day very effectively. And I think it's been an absolutely great meeting. Thanks to our participants, our speakers and our participants. You've made this a phenomenal day. So very, very happy indeed to have had this opportunity to see you all again, both our familiar friends and colleagues and our new members. Everybody has been terrific. So I think we should basically call it a day. What do you think, Vona?
Yes, I think that might be, unless anybody has some general comments about the papers and the approaches in total. That would be a big order. So I think it's
tall order.
End the meeting.
I think we can, but thank you. It's going to be uploaded. We will do some post-production. Each talk will be post-produced and uploaded, of course, to our video, our YouTube channel. So that will be on, but you have all been instrumental in making this real virtual event happen. And once we upload it, it's virtual, and everyone will be able to see it publicly. So thank you all very much. Vona, thank you for co-hosting. Rick, thank you for co-hosting. And I look forward to the next occasion when we all get together, either in this space or in the real one. Let's never forget about reality. But thank you so much, everybody. Bye for now.
Thanks a lot.
And thank you again. Your participation has been great.